Hi, good afternoon. My name is Dr. Gary Lee, and I'm I'm very honored here to be here today to share with you my recently acquired experience in treating COVID-19 patients. But before I begin, I'd like to clarify that I'm actually not a infectious disease expert. I'm an internalist, but I specialize in oncology patient. But as many of you already know, Taiwan was hit by a wave of infection since early May, and since then, a lot of the patients were admitted into our hospital. Our hospital is actually located right in the epicenter of the pandemic, so naturally, a lot of the patients was transferred or admitted into our hospital, and the sheer number of patients quickly overwhelmed the hospital. So what happened was different doctors of different specialties they have to step in and they have to also help with taking care of COVID-19 cases. And what really helped, one thing that really helped different specialties in taking care of these patients is by having a very well-defined, very clear protocol to follow. And we're quite fortunate that we have a very strong infectious disease department, and they really helped to ease the pain of transitioning into this role, and by coming up with a very easy to follow guideline. And so I believe my job here today is to share a very typical case of COVID-19 pneumonia and to start the discussion, and also to share some of the key aspects in treating COVID-19 infections, which was incorporated into our protocol. So I don't have a lot of time, so let's just get right into it. So the patient of interest today is Mr. Chen. Mr. Chen is a 41-year-old male. He's a very typical office worker, and he doesn't have any bad habits such as smoking, alcohol use, or chewing betel nuts. And his medical history was early stage CKD and hypertension, and he's currently controlling them with using losartan use, 80 milligrams QD. And his symptom began roughly 5 days before he was admitted into hospital, and his symptom manifested as sore throat and low-grade fever. And this was the time course and exposure history. First, his uncle was diagnosed on May 21st with COVID-19. A couple of days later, he started to have different symptoms like sore throat, low-grade fever, and progressive cough. And a few days later, his mother, who he lives with, was diagnosed with COVID-19, and she also had similar symptoms. So the patient was quite alert. So on the next day, he contacted our health department, and he was referred to our emergency room for further management. But by this point, he was starting to feel shortness of breath. At the emergency department, his initial vitals were unremarkable, and his saturation was stable under room air. Physical examination didn't show any abnormal findings. His lab was as follow. It was largely normal, and LDH, PCT were within normal limits. CRP was elevated to 5.19, and we naturally conducted SARS-CoV-2 RNA PCR, and it was positive. And E-gene CT number was around 22. This was his initial chest X-ray, which showed bilateral ground glass opacities. So the patient was admitted into our COVID ward, and upon hospitalization, we noticed that his saturation was a little bit lower than it was before. On the room air was only around 92 to 94%. So we started using oxygen and oxygen supplementation with nasal cannula. We also started dexamethasone, 6 milligrams, sorry, this is a typo, on a daily basis, and we'll also apply for remdesivir use. So for COVID-19 infections, we frequently categorize them according to their disease severities. So on one hand, you have a symptomatic patient or patient with mild illness, and as the severity progressed, you began to have patient with clinical radiographical evidence of a lower respiratory tract disease, and we would categorize them as moderate illness. And as the disease progresses and you start to see more severe patients, and these patients typically present with lower saturation under room air, or if they were to present with respiratory distress, such as a higher respiratory rate or having a very prominent lung infiltrate on chest X-ray. So these patients will be categorized as severe illness. And for critical illness, are patients who suffer from respiratory failure, shock, or multi-organ dysfunction. But based on treatment, we could really separate the patient into two large groups. Patient on the on the lighter end are asymptomatic patient or patient with mild disease or moderate disease. These patients are typically managed by supportive care alone. But for patients with more severe diseases, these are patients that require O2 use. They usually require more intensive treatment, and there's a lot more treatment options available. And based on the pathogenesis, these patients are usually under higher level of inflammation. So the pharmacotherapy are usually targeted at lowering the patient's inflammation level. So this is the abbreviated protocol that we use in our hospital, which basically tells us what kind of treatment is recommended at different severity levels. As you can see, for the mild and moderate disease, and these are typically patients that doesn't require O2 level, we usually just treat by supportive care alone. We treat their symptoms and we apply whatever their symptom requires us to do. But one of the key aspects to manage these patients is to monitor their saturation very closely, because COVID-19 pneumonias are very well known for having silent hypoxia. So some of the patients, they might appear asymptomatic, but if we were to measure their saturation level, they will have low saturation level under room air. But for severe diseases, we have few available medical treatments. These include dexamethasone, tocilizumab, which is an interleukin-6 inhibitor, and also remdesivir. And these are the recommended dose. So usually we apply dexamethasone to all the patients that require O2 use. As for tocilizumab, we usually only use it on patients with higher level of inflammation presented by higher level of CRP level. And the cutoff we use is CRP larger than 7.5. And remdesivir, we usually reserve it for patients in the severe disease group, but not for the critical disease group. So after the said treatment, the patient's disease continued to progress, and he became a little bit more his shortness of breath progressed a little bit, and his O2 demand increased from nasal cannula 3 liter to aerosol mask 8 liters. So by this point, we follow up his chest X-ray, and you can tell there's a very obvious progression of bilateral ground glass opacities. And we also follow up his laboratory studies. And again, his hemogram and biochemistry was within normal limit. This time we'll also check D-dimer level, which was actually quite high. So at this point, we started using awake proline protocols, and we also started using low molecular weight heparin as thromboembolism prophylaxis. As for the awake proline protocol, this is the one we used. The data on awake proline COVID-19 pneumonia is rapidly evolving, but at the moment, there's actually very limited direct evidence on its benefit. But the optimal protocol has yet been established, but it's actually widely used in many different countries, especially in countries where their medical resources are a little bit more strained, like India. And the reason is that by using this protocol, that some of the patients might be were able to avoid O2 use or intubation, which would save a lot more resources. And as for anticoagulation, COVID-19 pneumonia is quite well known for having an increased risk of thromboembolic event. And there's actually quite a few clinical studies which showed using prophylactic dose of low molecular weight heparin actually decreased the patient's mortality as well as risk of thromboembolic event. But the problem is that a lot of these studies are conducted in the West, and the impact of ethnicity on this issue is not very well known. And as you all know, Asian patients are less prone to thromboembolism. So what we do is we adapted the protocol. We only use a prophylactic anticoagulation on patients with higher higher D-dimer levels, and the cutoff we use is 1,000. So after we use these protocols, the patient's condition gradually improved, and his O2 demand was gradually tapered from room air to room air on the 8th. So by this point, we also follow up the patient's chest X-ray, and we could see the GGO rapidly regressed. So on the 9th, we checked the patient's PCR, and this is roughly around 10 days after hospitalization. So at this point, the patient's e-gene CT number was increased to 33. So with improved general condition, he was subsequently discharged on the 10th of June. So this concludes the case, which was a very typical, very simple COVID-19 pneumonia case, and I hope that demonstrated some of the key key intervention that we use on a typical patient. And that is the gist. Thank you.
Okay, thank you. Good evening, my friends from Myanmar. It's my great honor to have this talk to share our experience with you. I know Myanmar is a country like Taiwan, which is suffering from political dispute and turmoil and the concurrent invasion of the COVID-19 disease. So as an infectious disease specialist, I hope I can provide my best help for you to fight the disease, to fight against this very tricky virus. So today I'm going to give you a very comprehensive review about current data and literature review of everything we know so far about COVID-19 disease. But since this is a new emerging disease, so the data and publications are gradually accumulating. So maybe something you think this is right this month, maybe it will be overthrown by other data or other publications or other study next month. So we will try to update everything as soon as possible. And so I will provide my slide to Audrey and Dr. Lu so she can share them with you all so you can read it after the talk. So I know there are some time restraints, so I will begin my presentation as soon as possible. So for those who feel interest in these slide sets, you can also visit the clinicaloption.com or InVivoGen or CDC, US CDC to get the latest information. And before our talk, I would like to give you some definition of our current understanding about this disease. First is there are two terms that may be conflicting for some junior medical student or some junior doctors. Some people use SARS-CoV-2, some people use COVID-19. And so if we mention of SARS-CoV-2, it means the virus itself, which when you get infected with this kind of virus, the clinical disease is called COVID-19. So SARS-CoV-2 is a virologic term. It means it's kind of RNA virus and it's the pathogen of the COVID-19. So when you get infected with SARS-CoV-2, basically, so SARS-CoV-2 means the RNA virus itself. But when you get infected with this kind of virus, basically around 30% to 40% are actually asymptomatic. But for these symptomatic patients, it can range from mild disease, moderate disease, and severe disease. And so the disease classification, we will talk about it later. And this is a cartoon of the virus itself. Basically, it was a very typical virus. It was content of some spike protein, the envelope, and the non-structured protein, including the RNAs and the RNA itself. But the spike protein, it can attach to our ACE2 receptor in our human cells. So that's why it can lead to human infection instead of the animal disease. And previously, we also know some other forms of coronavirus like SARS, like MERS, they can also lead to human disease. But each kind of coronavirus, basically because of their virulence factor are different. So their mortality rate and their infectivity are totally different. Just like SARS-CoV-2, right now, according to our understanding, their infection efficiency are much better than the SARS and the MERS because even during the asymptomatic stage, they can transmit to others. But for SARS, you need to have fever first, then you can transmit it to other people. But very luckily, the mortality rate of SARS-CoV-2 is relatively lower than MERS and SARS. For SARS, the overall case fatality rate is around 10%. For MERS, the case fatality rate is around 30%. But with very, very good proper medical care, actually for COVID-19, we can decrease the mortality rate to around 1 or 2%. So that's why we need to give this lecture today, because I hope I can give you a better understanding about the care of this disease. So we will take a look of the global epidemiology right now. And I just update it according to the world meter on July 13th. As you can see, the confirmed case around the world is around 198 million people right now. And US and India are the most affected country right now. But as you can see, the US, the India, or the Russia, or the France, basically they have a very good medical care system. So if people get infected with COVID-19, basically they have PCR or rapid antigen tests to confirm the diagnosis. But in other resource-limited area, for example, South America or Africa, basically, if you don't have the medical equipment to confirm the diagnosis, it will be underdiagnosis. So it is a huge problem. And according to US CDC, this disease, unlike other infectious disease, for example, if you have pneumococcal pneumonia or if you have influenza, basically the mortality rate curve is a U-shaped curve. For kids younger than 5 years old or people are older than 70-year-old, they have highest mortality rate. But COVID-19 is totally different from other type of pneumonia. As you can see, people all younger than 5 years old, they have very, very, very low mortality rate and hospitalization rate. But for people with a higher age, like older than 65 years old or 70-year-old, their mortality rate will be higher. According to the Taiwan experience, if your patient get infected with COVID-19, and if their age is higher than 70 years old, basically their mortality rate is higher than 30%. So as you can see, for elder people, it's a very dangerous disease. But for younger kids, they are quite safe for them, but they can still transmit it to their family. So you need to be cautious about it. Then we would like to talk about the mode of transmission. As you can see, this kind of tricky virus, basically it's an airborne disease. So they can be transmitted through contact, very close contact or droplet. But it can also be spread through aerosol generation. What's the difference between the droplet and the aerosol? Droplets are large diameter droplet. And usually the diameter is around 5 to 10 micrometers. So the range of spread of the droplet is kind of lesser than 2 meters of range. So a very surgical mask or keep social distance can keep you safe from droplet transmission. But this kind of virus, they can also be transmitted through aerosol, so they can spread to very, very long distance, especially in the overcrowded area like the concert or a hall or school or a camp. So if the space is overcrowded and the ventilation rate is not so good, then they can be transmitted through aerosol. And the third way of transmission is through the fomite. Because this kind of tricky virus, they can survive in the surface of plastic or paper or copper for nearly 72 hours. So if an infected patient, they spread their droplet to fomite, for example, the surface of furniture, the surface of keyboard, the surface of a bus. And if you contact with the live virus, after maybe 40 hours or 50 hours, the virus is still alive. Then if you contact with the virus and contact your mucosa, then you can still be infected. So I will say that it's a very, very tricky virus. Some study from mainland China is it's a bus. It's a study from a bus. Some monk, they are going to a Buddha worship. So they take a bus to the temple. And if the virus can only be transmitted through droplet, then usually only victims around 2 meters in diameter from the index place will be infected. But as you can see in the crowded space with very limited ventilation, everyone, almost around 50% of the monk in this bus are getting infected with this virus. So it's an indirect evidence showing that this kind of virus can be transmitted through aerosol. Some other studies in Japan and other countries also show that within an enclosed environment, their infective rate is around 20 times higher than an open space. So it means it's not only transmitted through droplet, it can be transmitted through aerosol as well and the contaminated surface. So we need to perform a very, very good hygiene, including to keep social distance and including the good ventilation of our space. This is another study which was done in mainland China as well. There are some total 5 families, they enjoy their feast in a restaurant. But you can see from the air condition A, the airflow rate is like this. And for air condition B, the airflow is through this way. And the index patient is here. You can see the distance, even this desk, the desk E is very close to the index case. They did not get infected because the airflow direction is totally different, so they are safe. But for other people in desk B and desk C, I would say table B and table C, because of the direction of the airflow, around 8 to 10% are get infected with this virus. So as you can see, it's kind of another indirect evidence showing that aerosol can transmit this virus very efficiently, especially in a crowded space or closed space. So ventilation is very, very important for the transmission of this kind of virus. And besides, this is, just like I said, it's a very tricky virus. So it can transmit it through, even though you are still asymptomatic. According to our previous experience, if you are exposed to this virus and get infected, the median time to have symptoms is around 5 to 7 days. But around 2 days before your symptom onset, you already start to spread this virus. So if you only begin to isolate a case when he has symptoms, it's too late, because 2 days ago, he already started to spread the virus. So his family or his colleague or his friends, if they had contact with him 2 days prior to the symptom onset, they can still be transmitted with this kind of virus. So according to our CDC, according to our current regulation, if you find an index case, you need to trace everyone who get a close contact with him 3 days, since 3 days prior to his symptom onset. And you need to quarantine all of them because all of them are potential case of this kind of disease. You need to be very cautious about it. If you forget to quarantine these people who had prior contact with the index case, then probably it will lead to another outbreak. So it's very, very important. And so the key consideration of the modes of SARS-CoV-2 transmission, it can be transmitted through the droplet, like the coughing, like sneezing, thinking, talking, or breathing. But in enclosed space or crowded space, you need to remember that it can be transmitted through arousal. And besides, this kind of virus can be still alive within a couple of days after they are coughed. So if you have a contaminated surface, like in the hospital, if you have a contaminated desk surface or contaminated keyboard or contaminated knob, you need to clean them with alcohol or peroxide hydroxide because they can kill the virus effectively. But if you forget to clean the surface, the next one who contact with the surface is probably get infected accidentally. You need to remember this. This is very important. So for the non-pharmacological prevention intervention, just like I said, first, you need to keep social distance and wear a mask. Because if you can wear a mask properly, it can effectively reduce the R naught. Because if the R naught is around 2 to 4, according to current study, if everyone wear a mask, including the patient and other uninfected subjects, then the R naught could be reduced to nearly 0. But if only the patient wear the mask and he doesn't know he already get the disease, and when he cough, when he talk, during the asymptomatic stage, he can still transmit the virus to other people, then the epidemic will not stop. So it's a very important thing. And besides, you need to keep distance, keep ventilation, and to remember to clean the contaminated surface with ethanol, peroxide, or hypochlorite. This virus, it can be killed through either ethanol or peroxide or hypochlorite. You can get them very easily, I believe, because ethanol can be available everywhere. But you need to remember to clean the surface first. So I would like to remind you the importance. But why do we need this non-pharmacological intervention to reduce the magnitude of the outbreak? Because I will talk to you about this study later. Because if 100 of patients get infected with COVID-19, around 20% of them will become severely ill, which means they are oxygen dependent. So if 10 million of people get infected with this kind of virus concurrently, then you will get 1 million of people, they are oxygen dependent. No country can tolerate this huge number of people who need oxygen. So just like you see the news before, like India, even though they have a lot of industry who can manufacture oxygen, they still do not have enough supply for the oxygen to their victim because they have too many sick patients at the same time. Even in developed country like Australia or Europe or United States, you can see like last year in last March or in last May, the mortality rate is around 10% or 20% because their hospitals are overcrowded with these oxygen dependent people. So we need to smooth the magnitude of this outbreak. So our medical institute can afford to take care of this patient. So that's why we need this non-pharmacological intervention, because even though we will be infected with this kind of virus, if only a small number of people are getting infected, then these oxygen-dependent people will be fewer. But if a large amount of people are get infected at the same time, for example, a whole village or a whole city get infected. Like I said, if 10 million of people are get sick at the same time, then 20% of them will be critically ill. So there will be no hospital enough for these people. So that's the importance to smooth the dynamic of this disease is so important. And some people will talk about herd immunity because they believe if enough people are get infected with this virus and they develop natural immunity, probably we can get herd immunity so nobody will get sick anymore, like the measles or like the influenza. But you need to know the herd immunity threshold, it depends on the R naught of each disease. R naught, it means during a disease course, how many people will be transmitted by the index phase. If the R naught is 4, it means during your disease course, you probably will transmit it to 4 other people. If the R naught is 16, then it means during the disease course, you will transmit to 16 other victims. So for some disease like measles, the R naught will be around 15 to 16. For seasonal influenza, the R naught is around 2 to 3. According to our current understanding about COVID-19, the R naught is somewhere between 3 and 5. So the threshold of the herd immunity will be 1 minus the inverse number of R naught. It means if the R naught is somewhere around 5, then it means the threshold of the herd immunity will be around 65 to 80%. So if 80% are already get infected with the virus and get the natural immunity, you can see, I believe in Myanmar, there are around 50 to 60 million of people. If 80% of them are get infected with this kind of virus to get the natural immunity, then it means around 40 million of people are get infected. And if 20% of them become severely ill, it will be a huge number. So no hospital can take care of so many people. So to reach the herd immunity threshold through natural infection, it's impossible because it will result in too many causalities. So that's why we need vaccine, because the vaccine can help us to establish the immunity through an active way. So nobody will get hurt, but they can still establish the immunity. But there are some problems because we don't know how long the immunity can last for a vaccine or from the natural infection. Besides, the SARS-CoV-2 is kind of RNA virus. The RNA virus like hepatitis C or HIV, they can mutate it easily. So you can see we have very large number of different variants of the SARS-CoV-2 right now, like the alpha, like the beta, like the delta, like the gamma. So some of them, they will have decreased affinity to our current antibody. So the natural immunity, we still don't know if they can help us to prevent the disease from these mutants. So it's also an issue. So we believe that vaccine is very important because it can help us to fight the war against current strain of the SARS-CoV-2. But probably we need a booster, maybe every 1 or every 2 years to face other variant. And we will talk about the variant virus later. And then we will talk about the screening and diagnosis. Based on the WHO suspect case definition, previously, if you have some airway symptom and if you have a close contact with the infected patients, or if you visit an endemic area, then WHO will suggest you to do the screening diagnosis procedure like antigen test or PCR test. But right now, we already understand that around 30% or 40% of them are basically asymptomatic. It means some of them never have cough or fever or any airway symptom. So if you have a very close contact, and according to the epidemiology link, if you need to test someone to make sure if they are getting infected, then you can test them. It is not only depends on the symptom. Even though if you are asymptomatic, if the epidemiology screening is needed, for example, if you are a healthcare worker and you accidentally exposed to someone who get infected with SARS-CoV-2, and you need to take care of other healthy patient tomorrow and weeks after, then we will suggest you to do the screening procedure like antigen test or PCR test to make sure that you are not asymptomatically infected with this kind of virus. So the test is not only based on your symptom, it also based on your exposure or risk. You need to remember this. Yeah. So it's just like I said, the US CDC already also suggests if you are asymptomatic, if you don't expose to anyone who get infected and your occupation provide little risk to other people, then you don't need to test. But if you have symptoms and you already had close contact with an infected subject, or if your occupation mandates your testing, then you need to be tested. But we have these three different kind of tests for the SARS-CoV-2. Just like we said, we have PCR for the nucleic acid. We have some rapid tests for the antigen assay. And some people will talk about the so-called antibody assay to check the IgM and Ig. What's the difference? We will talk about it later. Generally, in Taiwan, in most situations, we test people through the PCR to test if they get infected with this kind of virus. The PCR, we are trying to look for the nucleic acid because the sensitivity and specificity rate will be around 99%. But it's very labor intensive and it's expensive. So in resource limited area, antigen tests can replace the role of the PCR. Although the antigen tests, they are less labor intensive, but you need to remember that the false positive antigen, the false positive rate of the antigen test is around maybe 20%. So if you test a totally asymptomatic subject and he has no known exposure to an infected patient, then the antigen test will have a higher false positive rate. So the antigen test, we only limited them to someone with symptom or if he already have known exposure. So for antigen tests, we did not recommend it to test everyone, only for the symptomatic subject or during a local outbreak. For example, if you have an outbreak in your institute and you need to understand if everyone in this unit get infected, then you can use the antigen test. But if you provide the antigen test to everyone on the street or test it in the school without any known outbreak, then you will have a lot of false positive subjects. Then it will cause a huge problem. So remember that nucleic acid is more sensitive and more specific, but the cost is very high. You need the machine and you need the medical technician to do the test. So it's very, very labor intensive. So in resource limited area, I will suggest you to do the antigen test instead of the PCR. But remember the false positive rate. So you should not provide the antigen test to everyone. And in terms of the antibody test, it could only provide some evidence of the epidemiology link. It cannot detect the patient with acute infection because the antibody will become positive around 2 to 3 weeks after your infection. So for patient with acute infection, generally the antibody provide little help. But if you need to do an epidemiology link or epidemiology study to see how many people are already get infected or how far you are away from the herd immunity threshold, then antibody test can provide some evidence. So I only suggest you to do the PCR and the antigen test, but not the antibody test because it's only for epidemiology study. And some people will ask why the antigen test has so many false positive and false negative. Because the antigen test is only effective for patients with very, very high viral load. And when your specimens are collected very properly. For SARS-CoV-2 infected patients, their viral load are higher if your specimen are collected from their endotracheal aspirate, it means if they are intubated or if you have sputum suction from a machine. From their saliva or their throat swab, usually the viral load is lower than the endotracheal aspirate. So if you can collect the specimen very properly, then the antigen test will provide more information. But if the technique is not so familiar, so your specimen is not collected properly, then probably the antigen test will provide a false negative result. Besides, if you are far from your day of symptom onset, for example, our viral load is highest during the first week of the infection. So during the second or third week of infection, your virus can be still detected through PCR. But if you do the antigen test to these people, because of their viral load are already decreasing, then the antigen test will lead to a false negative result. So antigen test is more effective during the acute stage. But if you want to do a test of cure test, it provided very, very little information. Please remember this. And just like I said, the nasal swab, throat swab, or sputum, they provide higher viral load. If you test other specimen like blood, urine, or stool, their viral load is much lower, so they are less effective. So the timing of PCR and antigen tests, just like I said, during the first week, antigen tests will provide a more accurate result. But if you do the antigen test during the second or third week, it will be false negative. And if you do the PCR, generally the virus can still be detected even during the fourth or fifth week. But the CT number, it means the viral load will be much lower. So if the CT number is higher than 30, it means generally they will not transmit it to other people. So in United States or in Europe, generally they do not do a test of cure test because they know even during the fourth or fifth week of the infection, their PCR will still be positive, but it means nothing because the viral load is already low. They are already dead virus, and you will not transmit the virus to other people like your colleague or your family. So the test of cure is not needed if you are asymptomatic at that time. And during the symptomatic stage, generally the antigen test will provide an accurate result. But if you test during the second or third week, it will be falsely negative. And the antigen test is done through something like ELISA. I believe most of you are already very familiar with ELISA. So I will not go very deep to talk about the ELISA method. US FDA already approved a couple of different antigen tests. Each of them, they have a sensitivity or specificity rate around maybe 80 to 90%, but their costs vary. So I will not say which one is the best or better than other. The one you can get is the best one. So you don't need to purchase a very expensive one because their sensitivity and specificity are very similar. So according to US CDC, if you have a PCR test or if you have an antigen test like the rapid test, if you test the symptomatic patient, then either antigen test or PCR test, they can diagnose the SARS-CoV-2 very accurately. But if for the asymptomatic close contact case, like I said, if you need to do a surveillance of the healthcare worker, then the antigen test, sometimes they will be falsely negative because the viral load will be low. So the antigen test cannot provide very accurate information. So for this asymptomatic or close contact, maybe PCR can provide more accurate information, but if you cannot do PCR because of the resource limitation, like the machine or lack of the medical technician, then probably you can do the antigen test, but you need to monitor the false positive rate. But for asymptomatic one, and if they do not have any known exposure and their occupation do not need to know if they are asymptomatically infected. For example, if he's a farmer and he live alone, he will not transmit the virus to other people, then you don't need to do either antigen test or PCR, because if he will not transmit the virus to other people, the false positive result will only you cannot provide any very useful information for him. And we have some at-home use kit for the antigen diagnosis. Around 15 to 20 are already approved by US FDA, but I'm not sure how much of them can be purchased in Myanmar. I don't know. Some of them you can buy them in Amazon or some international merchant, but because this international business of this medical equipment are mostly limited by the legislation. So if you want to purchase it directly from US, you need to very cautious, because I worry that custom may block the international transfer of these antigen tests. So the best, most accurate diagnosis tool is the PCR. But I would suggest that if you do not have enough PCR equipment, you can use the antigen test to replace it. But remember, do the antigen test for the symptomatic patient. And if you want to test the asymptomatic patient, PCR can provide better information instead of antigen test. But for antibody assay, it's not useful for diagnosis of acute infection. So I will not suggest you to do that. And if you have a patient with symptoms, but your first PCR is negative or your first antigen test is negative, then what to do? According to previous experience in mainland China, around 60% of them will be positive during the first test, but around 30 to 40% of them will be positive during the second or third test. So if you have high suspicion of someone who will get infected with SARS-CoV-2 and the first test is negative, please remember to repeat the test maybe 48 hours or 72 hours later. According to our experience in our hospital, we have in-hospital nosocomial outbreak, and some of them are positive during the fifth time of PCR test, which was around 15 days later during the initial outbreak. So just like I said, it's a very tricky virus. So if some patient, you have very high suspicion that they have COVID-19, but the first PCR is negative, please remember to repeat the testing around 2 or 3 days later, because around 1/3 of them will be positive during the second or third test. But if the second or third test are already negative, then the chance of getting infected during the fourth or fifth test is around 1 to 5%. So in resource limited setting, I will not recommend you to repeat the testing so many times, because you need to save the test kit for other patients. But I will suggest you to do the second or third time if you have appropriate amount of testing kit. And some people will ask, if I don't have the PCR and if I don't have enough antigen test kit, can I diagnose a patient with imaging study? Because a lot of journal already told me they will have ground glass pattern or something. Just like I said initially, around 30 or 40 of patients get infected with with SARS-CoV-2. Basically, they are asymptomatic. It means they have no finding in their oxygenation or in their chest imaging study. So if you want to detect ground glass opacity in their CT film or in their chest X-ray, it's usually in the late stage. So it's not a very sensitive tool. You cannot use the imaging study to replace the role of PCR test or the rapid antigen test kit. And this is a cartoon graph to let you understand. That's why I said antibody testing has no role because the viral load it will rise initially. So during this stage, the PCR or antigen test will be positive. But the IgG and IgM will rise during the second to third week after your infection. At this moment, you can use the antibody to detect if they are previous infected with SARS-CoV-2, but it's too late because it only have epidemiology meaning. So if you want to test if someone with acute symptom, for example, acute hypoxemia or acute respiratory distress, if they have infected with this kind of virus, basically antibody detection has no role in such acute setting. PCR or antigen tests will be more accurate. And some will say that if the antibody will last forever, according to previous study in mainland China, the IgG and IgM will rise during the second or the third week. But if you are asymptomatic initially, then around 1/3 of patients, their antibody will decrease to a very low level after 3 months. But for symptomatic subjects, around 80 to 90% are still positive for their IgG during the convalescent stage. So it means it provides some hint that the antibody response will not last forever. So that's some indirect evidence supporting that maybe we need a second or third or booster dose of vaccine, because even during the natural infection, your antibody response did not last forever. So we believe that for vaccine, similar phenomenon will be observed. So I believe like influenza, probably annual or biannual booster of vaccination will be needed and essentially. And at-home test, in United States, they have some at-home tests. You can do the test by yourself, so you don't need to go to the hospital, so you will not have potential exposure to the sick patient. For some at-home tests, they use antigen tests, but for some like Lucira's COVID-19 test kit, it is used to test the RNA. So it's a very interesting at-home test, because for other at-home kits, they use the antigen test. But for Lucira, it uses a PCR method to let you do the test at home. But it's super expensive. So I would not suggest you to spend the very limited resource in their at-home test. But if you feel interested in this kind of kit, I will say the Lucira kit at-home test is a very amazing one, because you can do the PCR at home. You don't need the assistance from a medical technician. Then I will talk about the clinical presentation of COVID-19. Generally, the median time of symptom onset after your infection is somewhere around 5 to 7 days. And around 97% of them will have symptoms during the first 14 weeks. So if you do not have symptoms after 2 weeks after your exposure, then it means either you are asymptomatic infection or you did not get infection at all. The median time to symptom onset is around 5 to 7 days, but 90% of them will have symptoms within first 2 weeks. Most people think COVID-19 have airway symptoms, but basically it's a multi-system inflammatory disease. So you can have headache, you can have myalgia, or you can either have some viral rash in your skin, or in very rare circumstances, you will have some neurologic symptoms like dizziness, encephalopathy, or myocarditis, or thromboembolism, just like Dr. Lee said. According to United Kingdom experience, around 60% of them will have cough, fever, or shortness of breath. But for other symptoms like a lack of smell or lack of taste, generally it's around 30% of them have these symptoms. So none of them are very specific or very sensitive for COVID-19. So you can see cough, fever, and shortness and breath, they can be presented in every kind of respiratory infection. So it's a very, very non-specific symptom. So if you have a patient with any suspicion symptom, and if he has already known exposure to an effective one, then I would suggest you to do the testing. And for the young patient and elder patient, generally they have a little bit different kind of presentation. For young patient, they have airway symptom, but for elder people, generally they will have a non-specific symptom like myalgia, loss of appetite, or some GI tract symptom. So it's generally all of the symptoms are non-specific. So if you have epidemiology link or a cluster, remember to do the testing, because even for the loss of smell or for the fever or dyspnea or hypoxemia, none of them are very specific. Please remember it. And for lab testing, it doesn't like other type of pneumonia. Other type of pneumonia, you have leukocytosis or neutrophilia. But for COVID-19, generally, you will have a lower white W cell counts, and you will have a lower lymphocyte count. And for those with severe COVID-19, you will have a higher CRP level, higher D-dimer level, or other non-specific inflammatory marker like LDH. For some patients, they will have elevated liver function profile as well. So just like Dr. Lee said, our typical case has a higher CRP, higher D-dimer, and higher LDH level. So we included all of them in our initial test kit if a COVID-19 patient is admitted to the hospital. And some people will ask, will the hypoxemia develop during the initial stage? Unlike other type of pneumonia, if you have pneumococcal pneumonia or if you have influenza pneumonia, generally the hypoxemia will develop initially. But COVID-19 is a very tricky disease. You can have fever or cough initially, but usually the hypoxemia and the respiratory distress usually develop during the 2nd to 3rd week. So you can see for the survived patient and for the expired patient, they will have ARDS after around 10 to 14 days. So if you have a patient who was admitted to the hospital with the good oxygenation initially, it doesn't mean he will survive to discharge. You need to observe him for around 10 days or 2 weeks because hypoxemia will develop during the 2nd week. So you need to be very cautious about the disease. It's a very, very tricky one. So I will talk about the treatment later, but during this slide, I will say, if you have a patient during the 1st stage, it means the virus are actively replicating inside of his body. During this stage, antiviral agent will be effective. But if he already developed hypoxemia or respiratory distress, it means the cytokine storm already developed. Usually their viral load will be lower. So during this stage, the antiviral agent will provide little help for them. During this stage, dexamethasone, I mean steroid or some interleukin-6 antagonist antibody will provide best help for them. So if you very luckily see the patient during the 1st stage, then you can use remdesivir or other kind of antiviral agent for him because you can lessen the severity. But if you already see the patient during the later stage, I mean patient with hypoxemia, it means they already have cytokine storm, then remdesivir will not help him. Only steroid and tocilizumab is kind of antibody to antagonize our interleukin-6 will provide a survival benefit. I'll talk about it later. And Dr. Lee already mentioned about coagulopathy. This phenomenon is widely observed around the world, either in China or in Europe or in United States. People around the world already see that around 20% of their COVID-19 patients experience different degree of thromboembolism. It's because of the COVID-19. The virus itself, it can cause endotheliitis because it can also bind to the ACE2 receptor in our endothelium. It also causes the activation of platelet. So the activation of platelets and the endothelial injury both combined together, they will lead to microthromboembolism. So a lot of different kind of laboratory predictor of thromboembolism. You can see if the D-dimer is elevated, fibrinogen is decreased, CRP is elevated, ferritin is elevated. It means their inflammation cascade are already activated. Then they will have a higher risk of thromboembolism. And this is partly caused by the SARS-CoV-2 damage to our endothelium in our capillary. So in mainland China, I remember that some of our colleagues has asked if you will provide universal use of heparin. I will say no, if your D-dimer is within normal limit or only rise very insignificantly, like 2 or 3 times than the upper limit, then the low molecular weight heparin will not provide any survival benefit. But if your patient already have very active platelet activation, and if their D-dimer is three times higher than the upper limit of your laboratory test, then the use of low molecular weight heparin will provide a very significant survival benefit. So if you provide low molecular weight heparin unselectively, it means if you give heparin to everyone, then the mortality rate has no difference. But if you selectively only give those patients with higher D-dimer level, I mean at least 3 times than the upper limit. In Taiwan, our upper limit is 340. So I usually give patients with low molecular weight heparin for those patients with D-dimer higher than 1,000, and it can provide a survival benefit. But if your patient only have very low D-dimer, then heparin use will not help them. Or sometimes you will have a higher mortality rate as compared to the heparin non-users. So I will not say you need to give heparin universally. Please remember only give it to them with higher D-dimer level. And some people will say that if the high dose anticoagulant, for example, a therapeutic level or the prophylactic dose, did the higher level provided any better help for them? According to some study, if you have higher D-dimer level at ICU, then probably high dose anticoagulation can reduce the chance of the thromboembolism. But the survival benefit was not demonstrated. So it probably can decrease the chance of getting pulmonary embolism, but it seems you did not improve the chance to be discharged. So I will not say that current evidence can tell you high dose or prophylactic dose, which one is better. But because of in Asian population, generally our bleeding risk is higher than Western people. So in my hospital, I only suggest you to give the prophylactic dose instead of the high therapeutic dose. And the current recommendation only focus on the low molecular weight heparin. Currently, NOAC, like the factor 10A inhibitor or some other dabigatran or some other form of NOAC, they did not have a clear benefit demonstrated in randomized control trial. So I only recommended the use of low molecular weight heparin. Unless someone suffers from the heparin-induced thrombocytopenia, then under such circumstances, then NOAC probably may be feasible in this patient. But if you have the low molecular weight heparin and the patient is free from any adverse event, I would suggest you to use heparin instead of the NOAC, because NOAC is much more expensive and it did not provide any survival benefits. So I would not suggest you to routinely use this NOAC. Just use the heparin. I think it's adequate for your patient. And some people have asked if the antibiotic can help this COVID-19 patient. I will say that unlike influenza, in case of influenza, we have around 20% of chance of co-infected with pneumococcus or Staph aureus. But in COVID-19, the chance of bacterial co-infection is very, very low. in the experience from mainland China or from UK, it's less than 10% of patients are co-infected with bacteria. So universally give an antibacterial agent like a bromine or third generation cephalosporin or fluoroquinone, it cannot improve the survival. But if your patient are admitted to the ICU and intubated for maybe 2 weeks or 3 weeks, they will have a bacteria hospital-acquired pneumonia superinfection. The chance will be high. So for the initial management, I will not universally recommend an antibacterial agent. But for those severe patients who are intubated in the ICU, maybe after 1 week or 2 weeks of mechanical ventilation, then probably they will have a bacterial superinfection. So if they have a new febrile episode, a new onset consolidation in their X-ray, then at that time, antibacterial agent will be helpful at that moment. So in Spanish experience, only around 3% to 5% will have bacterial co-infection during the initial stage. So please remember, do not universally give them antibiotic because COVID-19 is a viral disease. And if you do not have bacterial infection, why do you need to use the antibiotic? And please remember that for ICU patient, because we will give them dexamethasone, and after prolonged steroid use, some people will suffer from invasive pulmonary infection, especially for fungi. In mainland China and in Europe, generally they suffer from invasive pulmonary aspergillosis. But in India, they said they have more mucormycosis. It's two different kinds of invasive fungal infection. But either way, they are related to potent steroid use. As high as 20 to 30% of ARDS patients will suffer from invasive aspergillosis. So if your patient are staying in the ICU and you have given them maybe 10 days of steroid use, please remember to check if they already have a concurrent aspergillus or fungal infection. Because if you have a fungal infection and you don't know it, the mortality rate will be super high, around 90%. So please remember to check their fungal culture or aspergillus antigen or aspergillus PCR. It depends on what kind of equipment do you have in the hospital. And then we will talk about how to classify their severity. I say that around 30 to 40% are actually asymptomatic. But if your patient are symptomatic, you can differentiate them from mild disease, moderate disease to severe disease or to critical disease, depends on their X-ray and their oxygenation. If your patient only have fever and some myalgia or airway symptom and his oxygenation is totally okay and his X-ray is totally okay, it means it has mild disease. And if he already has some infiltration in his chest X-ray, it means he has a moderate disease. And if his oxygenation is already lower than 94%, even though he has no acute respiratory distress, it already means he has severe disease. So you can differentiate your patient's severity based on chest X-ray and his oxygenation. If he already become oxygen dependent, please remember to give him steroid. And if he is during the initial stage, then probably a remdesivir or other kind of monoclonal antibody can help him. So the staging is very, very important, just like cancer. And for the symptomatic patient, around 80% of them are belong to the mild disease. Around 20% of them are oxygen dependent. So just like I said, if you have 10 million of them are infected with COVID-19, around 20% means 2 million people will become oxygen dependent. It's a very critical issue. So around our role in the hospital is to identify which people will become severe and which people will become critically ill. And the most important risk factor of become critically ill is the age of the patient. for as compared to people elder than 80 years old, if you compare people younger than 50-year-old and older than 80-year-old, their risk of death is 10 times higher than those younger people. For other kind of chronic diseases like cardiovascular disease, like diabetes, like obesity, their risk of death only increase only very minorly, only around 1.3 or 1.5. But age is the most important determining factor, because if you are elder than 80 years old, your risk of death is 10 times higher than the younger people. Just like I said, the kids and the adolescents are very safe from COVID-19, but for elder people, it's a very, very dangerous disease. So some people, they also develop a so-called scoring system like Charlson Index. Use your age, your sex, your comorbidity, your initial presentation, oxygenation, and some lab tests to differentiate the chance of mortality. If your score is higher than 15 or higher than 10, generally your risk of death will be super high. But if your age is younger and you don't have any oxygenation problem, your lab are totally normal, then the chance of mortality will be very, very low. So you can use this quick score to calculate the chance of survival of your patient, just based on some very simple calculation based on their oxygenation, their conscious level, and some initial lab. But remember that age is the most important determining factor. If you don't have any equipment in your clinic, if you cannot test the saturation, if you cannot test the CRP and renal function, age is the most important determining factor. Remember this. So so after we determine the severity, then we will talk about the treatment of the disease. Just like I said, during the initial stage, for example, during the first week, it's a viral replication phase. During that time, an antiviral agent will help these people. But if your patients are presented with hypoxemia or ARDS, it means they are already into the inflammatory cascade. Then at this time, steroid and oxygenation and some interleukin-6 inhibitor will help them. At this moment, antiviral agents will provide very, very little help for them. And this is US NIH guideline. You can see if you have a very mild patient, he only have mild to moderate disease, it means his oxygenation is totally okay. Then your goal is to lessen their chance to become severely ill. So at that time, some monoclonal antibody to bind to their virus, or dexamethasone or remdesivir can help them. But if your patient are already hospitalized and become oxygen dependent, or even intubated or under ECMO, then at this moment, steroid will be the most helpful. I will give you some study result later. And some people probably ask about ivermectin, because this one, some people say that it lessened the mortality rate in India. But in some viral culture, ivermectin can inhibit the replication of SARS-CoV-2, but the concentration is higher than our currently regular dose. So you need to expose to a higher dose of ivermectin. Besides, current cohort study and the randomized control trial did not clearly demonstrate a survival benefit. So unless in a clinical trial setting, if you want to regularly give your patient with ivermectin, I currently cannot recommend this. But if you have an ongoing trial, or if you don't have any other affordable treatment, then probably you may try ivermectin, because in vitro, it can help you to reduce the replication of the virus. And for other kind of treatment like chloroquine or azithromycin or anti-HIV medication, generally our current evidence show that they have any clinical meaningful benefit. So I cannot recommend you to use chloroquine anymore or anti-HIV medication anymore because current study has demonstrated that they are effective against the treatment of COVID-19. So probably you can give patient in early phase with remdesivir if you have remdesivir. For later stage patient, you can use dexamethasone because you can reduce the mortality rate significantly to around 80 to 60%. And if you have tocilizumab, you can add it to dexamethasone. If you don't have tocilizumab, you can use dexamethasone alone. It still provided some survival benefit because the dexamethasone, they have clearly demonstrated their survival benefit in recovery trial, which was conducted by the WHO. But remember that for all participants, if your patient did not become oxygen dependent, actually dexamethasone did not provide help. Dexamethasone only provided survival benefit in these oxygen dependent or mechanical ventilation dependent patient because these patients are during the hyperinflammatory stage. But for non-oxygen dependent patients, generally they are during the viral replication stage. So if you get dexamethasone to this patient, actually it will slow your eradication of your virus. So actually they will increase the mortality rate, though insignificantly. But for oxygen dependent patient and intubated patient, because they are during the hyperinflammatory stage, at this moment, viral replication is no longer an issue. So at this moment, dexamethasone plus other type of care can reduce their chance of mortality very significant. For example, for oxygen-dependent patient, it can become 80% chance to mortality. For mechanical intubated patient, it will reduce to even to 64%. So I would suggest in a resource-limited setting, at least dexamethasone is the best treatment you can give to your oxygen-dependent patient. But for higher dose of dexamethasone, just like Dr. Lee said, we only give 6 milligrams per day to our patient because in CODEX trial, it's another trial for higher dose of dexamethasone. It gives 20 milligrams a day to ICU patient. Initially, there seems to be a survival benefit. However, after 1 month, their mortality curve, they cross. Why? Because during this stage, people will have a higher chance of secondary bacterial superinfection. So these patients, they are dead because of they have bacterial secondary infection. So if you want to give your patient a higher dose of steroid, maybe you can see a little bit survival benefit during the stage, but after 1 month, your patient will die from adverse event of the steroid because of secondary infection. So if you want to give it a high dose, please remember, don't use it for a prolonged period because people will get maybe a secondary fungal infection or secondary bacterial infection like Pseudomonas or Acinetobacter. Then if you do not have adequate antibiotic coverage, they will be dead from the secondary infection. And for other type of steroid like hydrocortisone, or some people have as the role of methylprednisolone, according to our randomized control trial, they did not provide a clear benefit like we see in recovery trial of the dexamethasone. So if you have dexamethasone and other kinds of steroid, I would suggest you to choose dexamethasone in the low dose. Higher dose, it seems people will be dead from secondary infection. But if you do not have dexamethasone, probably you can give hydrocortisone or methylprednisolone probably in the equivalent dose. But if you have dexamethasone, I would still suggest you to give a low dose dexamethasone first because it can clearly show a survival benefit, unlike other type of steroids. Please remember it. So current WHO living guidelines suggest you to give oxygen-dependent or ARDS patient with the dexamethasone 6 milligrams per day from 5 to 10 days. Not longer than 10 days because people will have secondary bacterial infection. And other types of steroid, we do not have adequate evidence, but if you don't have DEXA, probably you can give them. because it's better than nothing. So equivalent dose of 6 milligrams of dexamethasone, it means you can give them orally prednisolone 40 milligrams per day, or methylprednisolone 32 milligrams per day, or hydrocortisone 160 milligrams per day. They are equivalent dose if you do not have DEXA. But if you have DEXA, I would strongly suggest you to use DEXA first instead of other type of steroid. For remdesivir, it's kind of antiviral agent. It was used to reduce the replication of the virus. For special population like the pregnancy or kids, their safety data are not enough. But if your patient are suffer from severe COVID-19 disease, if the benefit is higher than the risk, probably you can give the remdesivir to them if they have enough information and informed consent. But I will say that unlike dexamethasone, they clearly demonstrated a survival benefit in randomized control trial. But remdesivir is not an elixir, it's not a magic bullet. It cannot effectively reduce the mortality rate. It only demonstrated to reduce the severity of COVID-19 patient. It means, for example, if someone will become severe disease, become oxygen dependent, but if you give him remdesivir initially, probably he will not get oxygen dependent because he can have a very rapid viral eradication and avoid the cytokine storm. But if your patient already suffer from cytokine storm, then at that time, you give remdesivir to them, it has no any benefit to them. So remember, remdesivir cannot reduce the mortality rate. It can only lessen the severity. Consider remdesivir is a very expensive drug. I would suggest you to use dexamethasone first because it's cheaper and it has a clear survival benefit. But if you have remdesivir for this high-risk patient, for example, if your patient is older than 80 years old and he look quite well right now, but you know he has very high chance to become critically ill after 2 weeks, then you can give him remdesivir to avoid the chance to become oxygen dependent. But if your patient is already oxygen dependent or intubated, then save the remdesivir to other people because it cannot reduce the chance of getting mortality rate. And in United States and Europe, they have other kinds of anti-SARS-CoV-2 monoclonal antibody, but they are super expensive. And for other SARS-CoV-2 variant, like the Delta one, the binding affinity of these monoclonal antibody are decreased. So consider their cost and their reduced affinity. So I will not recommend you to routinely use this monoclonal antibody because I will suggest you to save the resource for other cheaper, more affordable and effective treatment. And in United States, they will give this monoclonal antibody to the high-risk patient, but consider the progression of the Delta variant. Probably this monoclonal antibody, their chance of use will be not so useful later. So I will not spend too much time on this monoclonal antibody. And about interleukin-6 inhibitor, in Taiwan, we use tocilizumab. We use this one. But for other countries, they also have some other JAK inhibitor because it's an inflammatory cascade. It can block different sites of the inflammatory cascade. It can reduce the hyperinflammatory status. And from different study, randomized control study, tocilizumab, they can reduce the chance of mortality in patients with mechanical ventilation or oxygen dependent, just like the role of dexamethasone. But if you give the tocilizumab to everyone, including those not oxygen dependent, then it has no survival benefit. It means just echoing our previous note. If your patient are admitted during the viral replication stage, then remdesivir is helpful. If your patient already entered the hyperinflammatory stage, it means if they have oxygen dependent, if they have ARDS, then only dexamethasone and tocilizumab can help them. These two agents can reduce their chance of getting mortality, especially for those patients with high CRP level. So if your patient has a very high D-dimer level and high CRP level, it means they have hyperinflammatory. If your hospital can check interleukin-6 level, then it probably can guide you if you need to use tocilizumab or not. But most hospitals, they do not have a testing kit for the interleukin-6 level. So you can use a CRP level as a guide because most hospitals can check CRP level. If your patient has a low CRP level, then probably you can save the tocilizumab to other people. It's an experience from Spain. But please remember, just like steroid, for patients with tocilizumab, if you use this one, generally they will have higher chance of secondary bacterial infection, especially for Staph aureus. So remember, if they have a new onset fever or new pneumonia patch during their ICU stay, please remember to check if they have a secondary VAP or HAP. And these are other supporting evidence to support the use of tocilizumab. And for some, if you do not have tocilizumab, if you do not have remdesivir, some other medication, like some people will ask about imifemivir or favipiravir. Generally, according to our current study, they do not provide it. Favipiravir, generally, they do not have a clear survival benefit. So I cannot recommend you to routinely use favipiravir or anti-HIV agent or quinine or azithromycin. But an interesting study in Iran, it's also a resource-limited area. They use anti-HCV medication because both of these ones, they have generic ones, so they are super cheap in Iran. They use sofosbuvir and daclataxivir. Both of them are anti-HCV agent because HCV is also kind of RNA virus. So both these agents can inhibit the RNA-dependent RNase. So they also have some in vitro antiviral activity against SARS-CoV-2. So in Iran, they use sofosbuvir plus daclataxivir to treat SARS-CoV-2. And they have some meta-analysis as well. And it shows the chance of survive. It improved the chance of survive, and it reached a statistically significance. So probably maybe it's a way to improve survival because both of these agents have some generic version. Probably you can purchase it from India or somewhere because they have a lot of different generic manufacturer. So that's an interesting data. So I'm going to show you because in Iran, they do not have remdesivir. So they use this kind of agent to improve the survival. They have stronger evidence than ivermectin or vitamin or favipiravir. So probably it's worth trial in resource limited area. And the last part, I will talk about SARS-CoV-2 variant because I believe most of you already heard about so-called Delta variant and Beta variant and some other different variant. This is a phylogenetic tree of the SARS-CoV-2 because it's an RNA virus, so it can mutate very easily. The orange one, the old clade is the original one from Wuhan, but it's no longer the epidemic strain right now. The epidemic strain is the GHGR and clade G. And you will say that it differs from I heard the Delta, the Beta, or different variant. Why you use the clade? Because we have a lot of different classification of this variant. This one is used by GSAID, and it's a very common use system during the SARS-CoV-2 study. But according to US CDC and WHO, since we have so many variants, what kind of variant has more important clinical significance? We can classify they as the VOI, VOC, and VOHC. What is a VOI? VOI is so-called variant of interest. It means this kind of variant already harboring some genetic mutation, which may probably lead to a higher risk of transmission or high risk of death, but it's just theoretically called VOI. But if some evidence, some study already shows the transmission rate or mortality rate are increased, then it means the variant of concern, so-called VOC. So our current variant Delta, variant Gamma, variant Beta belongs to this category of VOC. And currently, there is no VOHC right now because VOHC is so-called variant of high consequence. It means a very, very clear evidence showing our current prevention method or treatment method are ineffective. So right now, according to WHO or US CDC, we have no known so-called VOHC, but probably the Delta plus strain may be improved to increase the chance of transmission and decrease affinity. Probably you may enter the list of VOHC someday. We will keep monitoring it, right? But right now, we only have 4 variants in VOC and 4 variants in VOI. So this is a list of VOC and VOI. You may probably heard the alpha strain, the beta strain, the gamma strain, the delta strain. This from India, this from Brazil, and this from South Africa, this from United Kingdom. It's so-called WHO label because we have a lot of different kind of classification system, like this from a software called Pango, and this is like the website I said just add, and this another study use the next trend. They all have different kind of classification system, and they are harboring different kind of amino acid change. So WHO want to simplify the classification system, so they use some Greek alphabet like the alpha, beta, gamma, delta, and the delta, alpha, kappa, lambda to simplify their name. But right now, you are familiar with the delta and the beta strain. They both belong to VOC. I would suggest you to keep monitoring of the delta strain because it seems to have a decreased affinity to current our convalescent stage antibody. So probably it will decrease the vaccine efficacy. Also, we will keep monitoring of this strain of virus. So this is a evolutional graph, the final genetic tree. This is the original one from Wuhan. And then later it has a significant mutation to increase the affinity to our ACE2 receptor. It called D614G. And later it has gained other kind of mutation, which will increase their chance of transmissibility or probably the chance of getting sicker disease, like increase the severity. So that's the UK variant, the beta one, the Brazil one, and the South Africa one, and later the India one, the so-called Delta one. And these are where their mutation are. Most of them are in the receptor binding domain, because the mutation in receptor binding domain, sometimes they can increase the affinity to our ACE2 receptor. Sometimes because of the motoic change, our antibody decrease affinity to binding to the virus. So it means our ability to clear the virus are decreased. So generally the mutation in the receptor binding domain, they will make these strains become more virulent. Sometimes they will become more effectively transmitted. Some of them will reduce the affinity to our antibody and the vaccine, and some of them will become lessen the neutralizing activity or our neutralizing antibody. So these are the VOC strain right now. And it's a very busy slide because you can see different kind of mutation. They will probably increase or decrease the infectivity. If you have some interest, you can take a look in. There is a very good review in Nature. You can see what kind of mutation will lead to what kind of different change. But right now, it seems the D614G variant become the predominant strain around the world, either in UK or in Europe or in United States. It's already become the predominant strain. And D614G plus other mutation will increase the chance of infection and the chance of become severe disease. And even for this strain, this is the South Africa one. The binding affinity of our nature-induced antibody, they are more resistant to our naturally born antibody. So it means your eradication ability become lesser and lesser. That's why a lot of people will become reinfected with SARS-CoV-2 because of this mutation. So it will cause a huge problem. And that's a part of reason why probably we need to get a booster vaccine every year or every 2 years from now on, because the virus will emerge. So new variant will become a predominant one. So these are some slides. Because of the time restraint, I cannot spend too much time on this. It means the variant will reduce our vaccine efficacy, because whether you receive the Moderna one or the Pfizer BNT one, generally their affinity is decreased to the South Africa strain and to the Delta strain. So that's why Pfizer and Moderna and other countries are trying to develop a third dose or booster, because they need to modify their gene sequence to target against the South Africa and the India strain. And we have some additional vaccine data like the Novavax or some other vaccine from other countries like mainland China. Generally, the South Africa and the Delta strain from India, they all have a decreased affinity. So whether you receive vaccine from China or vaccine from Moderna or Pfizer BNT, they have best affinity against the original one and the UK one. But for the South Africa one and the India one, generally, I believe most of us will need a third or a fourth booster vaccine to have a better affinity. And so this is a list of other investigational vaccine. Because of time strain, we cannot talk too much on them. But generally, the mRNA vaccine and the adenovirus vaccine, they have best activity against the virus. If you receive the subunit one or the attenuated virus one, generally their immunogenicity are less effective as compared to the mRNA or the adenovirus vaccine. So if you can get the mRNA vaccine or the adenovirus vaccine, it's best. But if you do not have this one, and if you only have the inactivated one, or if you have the subunit one, I think it's better than no vaccine. But most of us will need a booster one, I believe. And for the vaccine side effect, generally, most of them are well tolerated except some local side effect. But for mRNA vaccine, because mRNA is a very potent immunogen, so if you give your patient mRNA vaccine, please remember to monitor them for at least 30 minutes, because some of them will have anaphylactic shock within 30 minutes. So usually, if you give your patient mRNA vaccine, please suggest them to stay inside for at least 30 minutes to monitor if they have any reaction like the anaphylaxis. For subunit one or that virus, generally, they have less chance of getting anaphylaxis. But I would suggest if you have enough time or enough equipment, it's better to monitor them for around 30 minutes. It's for the best of the patient. And these are some other reminding. I think you can read the slide. I will give the slide to Dr. Luo and the host. And I hope most of us can return to health life as soon as possible. If the vaccine coverage rate is adequate, then we can enjoy our normal life again. That's my talk today. I'm a little bit over time. I apologize for the delay, but I want to give a most comprehensive talk to you as much as possible. Thank you.